how does an internal medicine specialist who's in the Canadian Armed Forces end up a functional medicine specialist in this domain? It's a little bit of a story I'll just start with. I did do a diploma in tropical medicine under the behest of the military round about 2001, maybe 2000. And of course, that was in London, England. It was 4 months of good times. And, I learned a lot about vector-borne illness, mostly mosquito-borne malaria and dengue and Zika and chikungunya and all those good things that you get from mosquitoes, and a little bit about ticks. And little did I know, like less than 20 years later, every day I'd be talking about ticks in my office. And I mentioned as I retired, I had my first kind of taste of a chronic Lyme patient. And then round about 2006, after finishing a master's degree in public health promotion and disease prevention focused, I kind of gave up on conventional internal medicine. I was on staff at Mount Sinai. I was seeing a lot of sick people in the wards, all of which had what I would, not all of them, but maybe 75% had diseases that were preventable had they done something differently 20 or 30 years before. So decided then around 2006 that it was time to kind of retool the practice. So did IFM courses and kind of hung out a shingle as a functional medicine doctor after a while. And initially that landed predominantly in chronic complex illness. And so the first clinic that I started that was integrative in that way was in 2012, P3 Health, Personalized, Participatory, and Preventive. And Elliot Jacobson came as a Quebec refugee, medical refugee, and helped grow that clinic to be a bit of a behemoth. And then we've very amicably divided into two clinics. And so I'm based at Avenue in Davenport in mid-Toronto, and have now segued to include a much broader practice that's health promotion, disease prevention related to longevity medicine, biohacking, and leading a fulfilled life is the key. But the point of it is functional medicine, is the way of the future for medicine, or else we're pretty much dead in the water because it's unsustainable in the cost of the conventional system. But also, I do believe it is the way forward to help both at the chronic complex ill patient end, but also at the end of helping people live longer, healthier lives. And don't get me started on stem cells. So this is my favorite expression, and you've heard it already, but there is no silver bullet, but there is silver buckshot for all of these kinds of patients. So what is functional medicine? A systems and evidence-based approach that focuses on identifying and addressing the root cause of disease, i.e. keep moving up, keep asking why. Ask why 7 times, as the Japanese phrase goes. Each symptom or diagnosis may be one of many contributing to an individual's illness. And so the components of this include, and probably resonate with everyone in this room, so I'm probably preaching to the choir. It's patient-centered, truly patient-centered, prioritizing an individual's unique needs and history. It's system-based, recognizing that I personally believe we're a spirit experiencing a human body or a meat suit, and that meat suit is integrated in completely mind and body. And tomorrow we'll have a little talk about mindfulness, meditation, and the contemplative neuroscience that goes with that, which I teach on at U of T. Root cause focus. And by that, we look at not just what environmental causes might be triggering things, but what are the underlying personalized genomics that predispose to that. It's a whole person approach, and again, emotional, social well-being and fulfillment, meaning, purpose, consciousness, legacy, these are all actually critically important for us as humans on this planet to live well. And it's integrated. And so people are surprised at the kinds of therapies they can get under one roof in our clinics, Elliot's and mine and others, I'm sure, here. So we're looking most importantly at what are upstream versus downstream factors in these kinds of conditions. And I find that a lot of patients come in with preconceived notions that I just need my POTS treated. That's my problem. I have POTS. It says, yeah, you do have, but what caused that? And how far up can we move to find and extirpate the root cause? And then a lot of these so-called downstream or secondary causes might evaporate without requiring long-term treatment. Again, tomorrow also I'll get into some weeds around the genetics that we have found in our personalized genomic testing that predispose to some of this. It has been well established, for example, that certain HLA gene patterns, and this is work by Richie Shoemaker, predispose about a quarter of the population to have poor clearance of persister infections, poor clearance of mold, for example, and then a predisposition to developing this systemic inflammatory response and autoimmune disease. And we look very closely at detoxification pathways and poor clearance of chemicals and biological toxins. And then, of course, it's important to understand people's actual day-to-day life, what work they do, where are they doing it, how much time are they spending outdoors versus indoors. If they have pets that bring ticks indoors, it doesn't really matter. Person-to-person infections are something we haven't spoken much about, but those are relevant here. And then chemicals, heavy metals, we've touched on earlier. So this is just a bit of a graphic to point out what I would consider to be upstream factors in people developing chronic complex illness. I apologize, somehow PowerPoint went to a PDF that dropped all the last letters. But the genomics and immune dysfunction are, I believe, fairly important upstream factors, as well as lifestyle, microbiome, nutrients. I'll throw in there, I should have a box for mitochondrial dysfunction because that's way up high in the list of things that are contributing to people having chronic fatigue. Mold, MSEDS, or as we're now calling it, infection-associated chronic illness, toxins, mast cell activation syndrome, and multiple chemical sensitivity or environmental intolerance syndrome, as it's now called. And as I mentioned, POTS is probably a downstream phenomenon from autonomic dysfunction, vagal nerve injury. So diagnostic approach, well, we've already heard about the problems of trying to diagnose tick-borne infections, but diagnosing, broadly speaking, chronic fatigue requires a fairly deep dive. So we look to Dr. Hawkins' point at blood counts, and we can do a Cali on those and the liver enzymes, but we also look at hormones extensively. And to be honest, a high percentage of people are walking around, especially if they're perimenopausal women with hormone deficiencies. Lyme is a hormone disruptor, so often the HPA axis is messed up. And so looking for signs of inadequate cortisol awakening response, for example, that's important. Inflammation, certainly HSCRP is a marker, although in my experience, it isn't commonly elevated if people have Lyme alone. If they have Lyme plus a bunch of other things, it can be. Autoimmune markers, we routinely look for anti-thyroid autoantibodies, as well as ANA and other markers, because autoimmunity is a common epidemic in our society as well, and I personally think it's driven by the same problems, environmental toxins and persistent infections. And we look at a lot of the metabolic things that are required for your immune system to function optimally and all your other systems, so vitamins, minerals, and organ systems. I will argue that maybe CD57 is problematic, but I find NK cell levels, which can be tested for by Dynacare on OHIP in our province, actually quite useful. Having a very low NK cell level certainly is a marker of immune dysfunction and is commonly seen, and my experience in these patients, And when we're on the track of improving them, their NK cells come up. So it does have relevance. CD57, Dr. Hawkins trounced. I order them together typically. Another relatively new immune biomarker for you to be aware of if you're not using it is IgG subclass levels. So IgG 1 through 4, and the patterns that we see in that are suggestive but not specific for Lyme and other intracellular infections. IgG 1 and 3 being below normal are fairly characteristic. Lyme, Mycoplasma, chlamydia can do that. IgG 2 levels that are below normal, I am often seeing in people with other bacterial infections, strep and staph in particular. And weirdly, I've diagnosed probably half a dozen people since ordering this panel of immunoglobulin G subclass levels with IgG4 related disease where their IgG4 is 3 and 4 times elevated. And that encompasses a whole group of inflammatory fibrotic conditions that we used to not know what caused them at all. Retroperitoneal fibrosis, for example, as one of them are now grouped under this IgG4 related disease, and some people have that and not Lyme at all. Histamine and chromogranin A are the two biomarkers that I order routinely for identifying mast cell activation syndrome. There's a whole list of biomarkers for that. The problem is they get progressively more expensive. If you order them all, it's several hundred to $1,000. So I typically just look at these ones and clinical diagnosis of MCAS. Here's somebody with over here, exceptionally low level of CD57, but also almost no natural killer cells. And the other relevance of ordering this test and reacting to it is to provide interventions that may raise the NK cells. If somebody comes to the clinic in a Brinks truck, they can actually go off and have NK cell transfusions. They're predominantly administered by clinics outside of North America that also do stem cells. So you can get stem cells, you also get NK cells now. Otherwise, there are specific supplements, immune transfer factors, and some mushroom extracts that seem to have a benefit at raising NK cells specifically. At the bottom here, when you're ordering ELISpots from Armin Labs in Heidelberg, Germany, you can also order CD57, and it turned out this particular patient came in with that already, and the Dynacare testing aligned quite nicely with a very low level of CD57 positive NK cells. Yeah, I think we'll skip that because we've heard a lot about this testing challenges, and obviously Ralph did a very deep dive on that. But I will pay tribute to Vet Lloyd and Ralph Hawkins for this particular article, which dates back now, I think, to 2018. It was published, and looking at 3 different data sets, including a veterinarian data set, but also public health data sets. They concluded that Lyme was underdiagnosed 90% of the time, and that the actual rates of infection and the incidence was dramatically higher than public health is detecting. Current 2-step test failed to diagnose up to 90% of Canadian cases. Conservative estimate that in Canada there's more than 60,000 new cases of Lyme, substantial number of which become chronic, as you heard, per year. This is a very small print, but I will point out if you find an indeterminate in the first step, they often won't do the second step ELISA testing, but if you phone and beg, they will. And in this particular patient, the confirmatory testing was actually positive. So it is sometimes worthwhile to badger your local public health clinic. As I mentioned, when doing the full panel of serologies for tick-borne illnesses, you find some interesting things. This particular patient had both an indeterminate Bartonella serology and a relatively convincing bolded reactive 1 in 64 Rocky Mountain spotted fever. And that always surprises them that they, so I've never been in the West Coast, so you can get it here too. And this is my individual who has positive babesiosis serology from McGill Parasitology Lab. As I say, a very rare thing to have. Here's somebody who had recent Rocky Mountain spotted fever, even though the IgM doesn't show up, but a serology titer of 1 in 1,024 is kind of eye-poppingly high. So we did actually undertake to treat that. And murine typhus was highly positive, but likely a cross-reacting rickettsial infection. Bartonella, not infrequently, if you look hard enough, will have positive serologies to respond to. So a lot of patients come in and say, well, why are you testing me in the public health lab? It's useless. It's false negatives for Lyme are quite high, true, but if you have positive tests for the other tick-borne infections, we at least can say with some certainty you've had a tick bite from different types of ticks potentially, but having these serologic tests now actually enable them to go back to other specialists potentially and have a little more attention and a little less drive towards psychiatry referral. Other infections, other tests. So as mentioned, we do a panel on viruses, and I do think that West Nile virus, which shows up quite regularly, operates a little bit the same. High percentage of people get it without knowing and asymptomatic. Epstein-Barr and cytomegalovirus are frequently reactive, and then the question is it reactivated as a result of a tick bite and infections therein? Parvo B19, if they've got low hemoglobin, that would be an important thing to look for from a anemia perspective. Obviously, asking for thick and thin smears, I do routinely. They don't often show up what I'm hoping for, but I've occasionally had a positive blood smear for malaria or babesiosis. We saw from vets' talk the benefit of fluorescent in situ hybridization. These are fish-positive tests from IGeneX for babesiosis, which is probably one of the best indicators of active infection. And as mentioned, I do routinely the broad tick-borne Lyme and co-infection ELISpot panel from Armin. There's a fish from IGeneX for Bartonella, so that patient got some fairly aggressive Bartonella treatment, which we'll talk about tomorrow. Here's a Epstein-Barr virus that has an IgM, presumably reactivation or at least a recent infection. And so antivirals were in order. For those who haven't ordered IGeneX testing and seen how that comes, you at least get a sense of how positive and what the bands are that are positive for both IgG and IgM. And it's important to point out that the IGeneX lab has come up with their own criteria to call something positive. As you can see here, if you have 2 or more of the starred bands, which are theoretically more specific for Lyme, then that's considered a positive by IGeneX criteria, but CDC, New York State, and most provinces of Canada require 5 of the bands. And so my frustration, as should be yours, is patients that have undergone this testing have 4 bands positive, they have all the symptoms, but they are called negative. That's part of the problem with this sensitivity of the test. Health Genetics Center. This is a laboratory north of Toronto in Concord. They're doing PCR on blood and urine, and I fairly routinely will order the chronic fatigue panel for them, which does provide these infectious agent PCR results, and not infrequently we will see HHV6. And of course, you may know in the transplant literature, if somebody has HHV6, and are getting an organ transplant, they're going to be prescribed valganciclovir orally for the rest of their life because it's a nasty virus and can be persistent and definitely has a negative impact on the immune system. So when I see an HHV6 positive and or a cytomegalovirus positive, I will offer Valcyte or valganciclovir treatment. And in this case, this individual also had positive mycoplasma, which behaves like Lyme in terms of fatigue. So this fine printed slide basically shows a stepwise approach to a functional medicine complex chronic illness case. Obviously, ideally starting with the least invasive, moving to more invasive kinds of treatments and interventions, often multiple concurrent interventions, the silver bullet approach, lifestyle being a very important part of it, natural health products, conventional prescriptions or compounded prescriptions as needed. I think the mind-body medicine is critically important for these patients for many reasons, and we'll talk more about that tomorrow. There are energy modalities that many of them patients will have tried, and if not, sometimes worth considering. Infrared saunas, for example, can be very beneficial for detoxification path enhancement. Red light therapy, pulsed electromagnetic field beds can be quite good for pain. And there are oxygen therapies that have been shown in the literature to be actually quite helpful, including ozone and hyperbaric oxygen. A tribute to Dr. Neil Nathan, who has been a guiding light in the areas of chronic illness patients, especially those with environmental sensitivities. And he's more or less single-handedly put this and the impact of mold and mycotoxins on the map. His first book was called Toxic, and this is his recent follow-up book, which is hugely helpful because we see many of us these patients, and they're very complicated to handle because out of the gate, anything you try to give them makes them worse, including water. And there are definitely some principles that he has brought to light that are hugely helpful. And so first, reversing some of this negative neuroplastic change in their brain that has ramped up their autonomic system. They're kind of stuck in the on switch for sympathetic responses. Their vagal nerve is overloaded and dysfunctional, and their amygdalas are firing threat, threat, threat all the time. And so we have to down-regulate some of that because these have been neuroplastic changes developed over time that are negative. So how do we do that? There are online programs, one called Primal Trust that is quite effective for many of these people. I recommend they start those. Everything with these folks is start low and go slow. And also various vagal nerve retraining approaches, some of which I'll show you tomorrow. There are wearables. And then the other big principle is identifying at any given time in the journey of this particular complex chronically ill patient, what is public enemy number one? So what should we deal with that's the upstream root cause right now that you haven't dealt with? And more often than not, that is toxicities that they have in their environment that they're carrying, mold in particular, persistent infections that we've been talking about, we'll talk this weekend, and various other toxicities to look for. And then initiating treatment of the root cause is critical, but has to be done also for this sensitive group of patients very slowly and in a stepwise fashion. So I show this to patients quite regularly about, especially those that come in with a diagnosis or a presumption of Lyme and are expecting out of the gate antibiotics. So while that's not where we start anymore, because I think the more important thing to start with is all the interventions that will do that. Immune function needs to be optimized because it's almost always dysfunctional. And then looking at the infection-associated chronic illness side of things, also called MSIDS, we want to push them down at the same time, but doing so without causing harm if possible, which is why I don't start with antibiotics anymore. And so unfortunately, this slide used to have color on it, but I will just start with the big step at the bottom is the foundational approach, which is managing diet. I alluded to the autophagy piece, or mitophagy. The major thing that we know about that in terms of longevity, but also autophagy is important for your immune system, is you need to have intermittent fasting minimum for most people 16 to 18 hours. So the average standard American diet person who is eating 3 meals a day and 4 snacks a day and never goes more than about 3 hours without food is not going to have autophagy happening and is going to have problems. So a very important part of our chronic complex illness program is to have this assessed 3-day food record and then some interventions that are genomically based. We'll show that tomorrow from our nutritionist. Sleep. So we already heard that one of the major symptoms in Lyme is suddenly inability to maintain sleep. They can get to sleep. They usually are waking up and it's fragmented and they're tired but wired and can't stay asleep. So this getting people to sleep is a hugely important contributor to improving their fatigue out of the gate. So we have a number of tricks up our sleeve for that. Obviously, there are supplements. Long-acting melatonin is helpful in many. We can use prescriptions. I no longer prescribe anything except the orexin inhibitors group, which, by the way, have been the first sleeping medications ever to show a reduction of dementia development. On the other hand, everything else that's prescribed for sleep increases dementia risk. And for the folks who say, I sleep well every night, I take Benadryl, it's like 8 times increased risk of dementia in that group. So don't prescribe anything but the Xants, Lumbar-Xant being one of the first. That's Dayvigo. And there's another one called Qvivic on the market. In any event, these are helpful sleeping medications. Most of the rest are to be avoided, also because they're primarily addictive. Certainly the benzodiazepines and zopiclone, imivane, that group should be avoided at all costs. For folks that have deep sleep reductions, tomorrow I'll talk about some peptides that can be helpful, cleverly called delta sleep-inducing peptide, and a couple others that are good for sleep. Stress management. Part of this comes from the vagal nerve retraining, but I do believe folks can have significant benefit if they learn to meditate, and recommend MBSR, mindfulness-based stress reduction programs. Hormones, if the thyroid isn't optimal, the testosterone isn't optimal in both men and women, if they're perimenopausal, not on hormones, and having clear deficiency symptoms of estrogen, this is critically important to optimize and get them started. We measure many vitamins, and in the private sector, we can get almost all of them measured. When they're deficient, we optimize them. Multivitamins make no sense to functional medicine practitioners because if you're really deficient, you need a lot more. I'll tell you tomorrow about the vitamin D genetics that lead me to conclude some people need 15,000 units a day. You're not getting that in a multivitamin, so you need a lot more if you're deficient. And if you're not deficient, you didn't need the other 40 things that are in a multivitamin. So don't waste money on multivitamins or have your patients do that. And then a broader discussion around peptide therapies, which I've put at the foundation here because I'm finding them hugely helpful. The Lyme stack that we have, I'll discuss tomorrow. Once you've got the foundations in place, which can take a couple of months to do that, then we layer on next steps, which would be to identify with testing whether there are specific toxic excess toxins like mold, mycotoxins, but also other chemicals. I will just say that there are a lot of folks that are not truly gluten sensitive or celiac. They're just sensitive to glyphosate, which is Roundup. And in North America, our agricultural wisdom has been spraying glyphosate on everything is perfectly fine. In Europe, it's been banned for 30 years. So I think a lot of folks who are not tolerating breads, for example, but can do so in Europe, it's not the gluten necessarily, it's the glyphosate story. So you can actually measure that. and tell people whether they've got that. PFAS, the forever chemicals, pesticides, PCBs, these are all things we can measure, especially in folks that have appropriate exposure risk. And this toxic burden is fairly critical to address and ideally help them get rid of. And that's a whole process in itself we can talk about later. We use a fair bit of botanical and herbals, and we'll be hearing some of those. And then when all of that is not getting them back to where they want to be, I will just say, I would say the majority of our patients are getting functional, at least, if not almost complete resolution of symptoms by the time they finish step 3. But now I'm still using some combination antibiotics in those who are still unwell with generally good success. So that was a whirlwind tour of complex chronic illness management from a functional perspective. I think there might be some questions. Happy to take them.